Today we've got a very special guest. I hope that I'm doing this at the right time. I haven't messed up the times again. But we're going to be speaking with Kyle Stanley about the hashtag lip factor. And also, I want to ask him a little bit about, I think it's called oral facial design, or oral facial design. And I sent him a message right before I went live to make sure he was still good, and I hadn't heard back from him. So hopefully I didn't mess this up. But yeah, so our topic today is going to be a little bit about. We started this off, because we've been talking about global diagnosis, and we kind of finished off that whole global diagnosis topic today with the last post, and hopefully you've got a chance to see that Instagram live that we did with Bill Robbins, where he kind of goes through and explains the whole system of global diagnosis. Yeah, and Chago says, I did get a haircut today, finally, after 10 weeks. So I just got a message from Kyle, so it sounds like he's here. Let's see if I can find him online. Well, I'll give him a little bit of an introduction before, while I'm waiting for him to come online. So, for those of you that don't know Kyle Stanley, I'm sure most anybody who is on here does. He's a graduate of USC, and while he was there, he trained with the kind of king of biomimetic dentistry, Pascal Menier. I have to ask, I don't know if he was a classmate of Matt's. There he is. And then after finishing there, he went and did an implant fellowship, and now Hills. And I think he should be joining us soon. And now, of course, a world-known speaker,
hey guys,
author.
Hello everybody.
There you are. So I messed up my last Instagram live time, and so I was freaking out that I did a calculation mess up.
Oh, okay.
But glad to see you're here.
Yeah, I'm here. And yes, Matt Najad was my my partner in the aesthetics elective with Pascal. So we started working together in dental school. And then we were teaching together at USC with Pascal, and that was when we had this idea of doing a practice together.
Oh, nice.
Yeah.
So were you guys in the same class, or?
We were. Yeah.
Oh, nice.
Mm-hmm.
That's pretty awesome.
It was fate.
And how? Where are you from originally?
I'm from Orange County originally, so just an hour outside of LA.
Okay. Yeah, you look the part of a Californian.
Yeah, especially now with my long hair and stuff.
I know. So you haven't had? I guess you haven't had it cut since the quarantine started.
Yeah, and
okay.
But
that's
I
more
went
than
a long time without having a haircut before. I think because I was just lecturing a bunch, and then that turned into I was already 3 months late on a haircut, so now I'm 6 months late on a haircut. So yeah. But
the beard looks trimmed a little.
The beard is trimmed,
yeah.
It was getting pretty nuts during quarantine, and my wife, put the kibosh on it. So.
Yeah. Okay.
Yeah.
Yeah, I like it. It looks good. This is a good look.
Thanks.
It was getting a little wild.
It was.
I'll stand up for your wife, I guess.
Yeah. Right.
So yeah, I appreciate you coming on here, and I wanted to get a chance to talk about a couple things, and I did some internet. I always try to do some internet research, and it was funny when I went to your website, and I'm trying to read through some of your publications. I'm looking through. I'm like, you've done publications. You've got all this stuff on lip, and you've got this stuff on face, but then you also have stuff on there like dental material stuff. I was like, this guy does it all. He's got a range of different topics. But I wanted to. I'm just trying to learn a little bit about. I guess. I want to talk about lip factor, and then you guys have been doing the thing with the facial flow, which was a neat concept, which I want to ask you a little bit about that. And then also, I couldn't find as much on the internet about it's called the Oral Facial Study Club.
The Oral Facial Club, yeah.
Oral Facial Club.
Yeah.
Okay. Does it have a website?
Yeah, I can't remember what it is. I think it's oralfacial.club or something like that. I can't remember.
Okay.
Yeah.
I didn't do as much background research on that one.
That's all right. Yeah, we can talk about it.
All right, awesome. Um, so yeah, so I guess jumping right, I guess I'm not great at foreplay. I would just jump right into the dentistry
Let's do
because
it.
uh, so as far as so when you talk about the lip factor, and I know that's something that you do your lectures about. So you're lecturing both about too long and too short,
Yeah, I mean, the
or do you
basic
focus
idea
on too long?
is like bringing the lip into the treatment planning, because so
Okay,
much of what we were taught is just accept wherever the lip is, right? We
okay,
can't do anything about the lip. We'll change the jaw, we'll change the teeth, we'll change the gingival margins, the incisal edges, we'll move the teeth, but we always just accept where the lip is. And that was what I never liked. So that was when I looked and said, sometimes I'd be planning cases with like an orthodontic surgeon or an orthodontist where we're changing the jaw position to match the lip. And it's
okay,
like, this is crazy. We're doing bone surgery to match the soft tissue. Like, just change the soft tissue. And that
okay,
was where I had this idea to like bring the lip lift into dentistry and specifically into restorative dentistry so that
okay,
the dentist could plan with that in mind. Because like at every school, and I'm sure it's the same at your university, it was with mine, and every dental school that I've went to around the world, the treatment planning is like, okay, if you're doing a full art or full mouth reconstruction, start with the
mm-hmm.
incisal edge, right? How do you get the
Uh-huh.
incisal edge? You take wherever the lip is, you add 2 to 4 millimeters to it. That's where you put the incisal edge. And I started thinking like all of my patients are being treatment planned the same, irregardless
Mm-hmm.
of if they have a long lip, if they have a short lip, if they're older, if they're younger. We're treating all these people the same, and that just didn't make sense to me. So the examples
Okay.
that I give is, I don't know if I can move this over there, but the examples that, let me take this off. I'll move it so that you can see.
Okay.
I'll show you some stuff from my lectures
Awesome.
here. Let's turn this around.
Oh, awesome.
Here we go. Okay, so like this patient, great. She has a short upper lip. She has a concave upper philtrum. She has what we call an inferior bow of the lip, meaning that it makes like a little arc. So for her, great.
Wait.
We should use our
Okay.
traditional treatment planning, take wherever the lip is, add 2 to 4 millimeters. That's where it is. But on a
Okay.
patient like this, we shouldn't do the same thing. Because if we do, we're going to make her appear like she has maxillary excess.
Okay.
Because her lip was not that long when she was younger, right?
Okay.
And what we do as if this was a denture or veneers, we would say, okay, the incisal edge needs to be, at least 2 millimeters from where she is at rest. And if we don't put it there, she's going to look super old.
Okay.
But if we do put it there, she's going to look
So.
like she has vertical maxillary excess.
Okay. So it's not just about moving the lip to where you want it, it's maybe considering putting the teeth relative to the lip in an age appropriate or gender or race appropriate place.
Yeah, but like on this patient,
Oh,
you basically don't want to put it 2 to 4 millimeters from where it is at rest. You don't want to put it under the lip because then she's going to look old too. So the idea with this is we change the lip.
okay.
Okay, so like from the front view, I was being taught that this patient should be treatment planned the same way as this patient.
Okay.
And you see the difference here.
Yeah.
So that whole idea is just don't simply accept where the lip is and know that you can change it if you need to.
Okay. And as I'm looking at those pictures, I think one of the things I'm thinking in my head is like, of the people that are considering a lip, there's going to be maybe some percentage of them that were just born with a longer lip,
Yeah.
and then some of them it's age related.
Yeah. Let me show more cases. I knew I shouldn't have put it back. I've got more cases to show like that.
Okay.
Yeah, some is age related because we know that as we age, we lose elasticity of the upper lip. Also, the teeth
Mm.
get shorter from,
Uh-huh.
wear, abrasion, attrition,
Uh-huh.
erosion.
Yeah.
So you have this phenomenon where the lip is getting longer and the teeth are getting shorter. So our patients are
Uh-huh.
looking older and older. But then in restorative dentistry, we're giving them young teeth, right? We're giving them all this texture and mamelons and all this stuff. So they have
Uh-huh.
young teeth with an old mouth.
Okay.
And it just doesn't seem to make sense to me. So let me show
Okay.
you this case. Where is it? So this is from my friend Octavio Sintra in Brazil, one of the best orthodontic surgeons in Brazil.
Okay.
Beautiful girl. Okay, she's already had orthodontic surgery that didn't go very well, so she's coming to him for a second opinion.
Okay.
And when you look at her, he needs to impact her maxilla. Okay,
Uh-huh.
because look at this, right? So she has a hyperactive lip. Maybe not a hyperactive lip, actually. She has vertical maxillary excess. So
Uh-huh.
for her, the treatment should be impact the maxilla.
Mm-hmm.
But look at where her incisal edge is. Her incisal edge is perfectly placed on her lip.
Uh-huh.
So
So if he did just the VME, yeah.
if he impacted her, she's going to look old.
Yeah.
She's not going to show any tooth display at rest. So when I first showed him this, when we were doing a course together in Brazil, he's like, oh my gosh, I had nothing to do to this. I couldn't do anything to this lady. He would
Uh-huh.
have impacted her maxilla like, 2 millimeters maybe. When
Uh-huh.
he needs to impact her maxilla like, 8
More.
millimeters or
Oh, okay.
more.
Okay.
So yeah, these longer type, long face type of patients, she's not old. She
Yeah.
just naturally has this long upper lip that kind of matches her vertical maxillary excess.
Okay. I didn't even think about it. So it's, yeah, people that are gonna get the LaFort for VME, but their lip was in the right position relative to their teeth. If you just do the LaFort procedure to reduce the size of their skull, but their maxilla, then they're going to have just this long,
Yeah,
super
long
long lip.
hanging
There's
upper
something that
lip. Yeah, so the
so you
orthodontic
could.
surgeons were limited by how much they could impact the
Okay.
teeth or impact the jaw even. And then here's another case. So this is a guy, same thing from Octavio Sintra.
Uh-huh.
This guy needed double jaw surgery, not just for aesthetics, but mostly for sleep apnea. Okay, so he has
Okay.
like a short throat here, kind of a big tongue, needed more space, needed to make more room for air so this guy could breathe. But when you look here, he's already not showing incisal edges.
Yeah.
So if Octavio needs to impact his maxilla, I mean, the aesthetics will be terrible because look at how little he
Yeah.
shows when smiling. And
Yeah.
he needs to impact his maxilla.
Yeah. Hmm. Okay. And so I'm guessing when I mean, the oral maxillofacial surgeon is doing the jaw surgery. Is it typically, is it typically a plastic surgeon that's doing the lip surgery, and do they coordinate, or there's some people
Typically it
that do
is, but
both?
we're training dentists to do this now. We're training um, maxillofacial surgeons, we're training periodontists, we're training, surgically inclined general dentists. It really just depends on where you practice, the legality, your skills. But, if you
To do
can
the lip
do,
lift?
hmm yeah,
Oh, wow.
yeah. So, if you can do, um, an impacted wisdom tooth, you can do a lip lift. You just have to know how to
Okay.
do it the correct way. And like there's some states, like in my state, I can't do it. In California, I can't do it. Technically, it's out of
Okay.
my scope. But there's some states in the United States where you can do it, or in other
Okay.
countries. I mean, some of my friends in Spain are doing it. In Brazil, we taught a lot of dentists to do it down there that are really doing amazing things. So
Oh,
yeah,
wow.
but with my team, it's involved with the plastic surgeon that I work with, Dr. Ben Tale. and he does all the lip lifts for us.
Okay. And so he's doing it, coordinating it with, I mean, if he's doing it in combination with OMFS that's doing the jaw surgeries, they're doing it at the same time, or they're doing it separate times?
It depends. It depends. Yeah.
Okay.
If possible, we like to do that at the same time. If the patient's going to be in a
Okay.
hospital, going to be sedated, might as well get everything done. But
Uh-huh.
sometimes we will wait to do what is most predictable last. So we may do the
Okay.
lip lift first, let the patient heal so that the maxillofacial surgeon can impact the maxilla to the correct point of where the lip is. And the
Okay.
same thing, because we're doing this, we do it with maxillofacial surgery, but we're also doing it a lot with just like veneer patients. A
Okay.
lot of our veneer patients are having lip lifts before or after. And we coordinate this with Dr. Tale because we've worked with him for years. We've
Okay.
gotten pretty good at like who comes first. So we like to both do consults, and then we like to
Okay.
figure out who comes first in certain cases. And then
Okay.
if we can do digital smile design, do a motivational mock-up, or even like not even a motivational mock-up if the patient has already accepted the treatment, but just do a
Uh-huh.
mock-up, send the patient over to Dr. Tale with a mock-up in so that he knows where the new incisal edge is going to be, and he can
Okay.
plan the lip lift based on that.
Okay. And what's the I mean, first of all, I've seen pictures of when they've got these lip lifts or when they've completed, and of course I'm like zooming in looking like to see if you can see anything over here. You can't see any I mean, in the picture you can't see it. I mean, can you even see the incisions or anything, scar or anything in the
Very
patient's?
rarely. It depends on
Okay.
who's doing the surgery. The
Okay.
traditional type of lip lift was you take out the tissue and sew it back up. And
Uh-huh.
that caused scars. If you know anything
Okay.
about surgery, you have to release tissue or else you're going to have tension.
Okay.
And if you have
Okay.
tension on, an incision, it's going to pull away
Uh-huh.
and you're going to get secondary tension and scarring. So what Dr.
Okay.
Tale did is he changed the protocol to release the tissue a lot. So it takes
Okay.
all the tension off of the flap, which is why his cases have almost no scarring. Now, we do
Okay.
have cases that do have scarring, and those are usually patients that are like more acne prone, or if they're
Uh-huh.
like keloid forming patients, and those patients usually know that before they go into surgery. And
Okay.
then the last one is if they've had silicone in their lips, because
Uh-huh.
silicone just like when we take it out, it's just like this gucky stuff that just doesn't let you heal very well. So there are
Okay.
certain cases that are more prone to scarring than others, but I would say,
Okay.
probably 85% of our cases, their family members wouldn't even know they had anything.
Oh, that's awesome.
Yeah, it's
And they're, I
pretty
guess,
cool.
they're doing the I mean, they're doing the suturing just kind of right underneath the
Yeah,
nose.
so there's like a natural crease between where the nose and the lip meet, and that's where we
Okay.
make our incision, and that's where we keep that scar.
Okay.
So there's a natural crease, and it almost looks like you have a scar before you even have anything. So it really
Okay.
fits right there. And I think the problem that many plastic surgeons have done in the past is they've tried to not, or they haven't respected this natural line. So what they'll
Uh-huh.
do is they'll try to hide the incision in the nose, or they'll
Mm-hmm.
pull the lip up into the nose or
Okay.
something like this. And that never really works. You have to
Okay.
respect that demarcation and make your incision there and just be good at suturing, know how to do the technique well. And that's what really limits the scarring.
Okay. There's a question on there that says a question about lift lip versus fillers. I didn't even
Yeah.
think of. I mean, 'cause I guess fillers will push up the lip a little bit too,
Yeah,
or
so that's a little bit of a misconception. And
okay.
I wouldn't say most, a lot of the patients that we're doing lip lifts on are people that have
Oh,
had fillers for so long. So
okay.
people do fillers because they want bigger lips. Now,
Oh,
bigger lips oftentimes expand the actual tissue. So what they're doing is
oh,
making your lip longer. Even though you
okay.
have more red lip, oftentimes the philtrum will lengthen.
Okay.
And so when you
So,
see a lot of these people that have had fillers for, 5, 10 years, they show no
mhm.
tooth display at rest. So
Oh,
they're trying to look younger, and they ultimately end up looking older and
okay.
unnatural. It changes the facial thirds. Your last post, it changes those
Oh,
facial thirds and make them appear like they have vertical maxillary excess. So
okay.
the lip lift was first really invented for what's called the senile upper lip. That means old,
Okay.
right? So,
Okay.
patients in their 50s, 60s, 70s, 80s, right? And
Uh-huh.
they've lost elasticity, their lip has lengthened. But what we found is with many of our patients now, they start getting fillers when they're 18, 20 years old. And so by the time they're like 25, 28, 30, their lip
Uh-huh.
has already expanded so much that they need lip lifts before they're even in their 30s.
Okay.
And so they've come into us like, hey, I want to get veneers and I need to lift my lip here. Or, they
Uh-huh.
either come to the plastic surgeon or they come to us and we kind of refer to each other.
Uh-huh.
And, it's something that I think if you ask plastic surgeons 20 years ago, would you ever do a lip lift on a 25 or 28-year-old female? They would say, no, you're crazy. Why? They don't need it. But
Yeah.
because we've
I know.
expanded the lips so early
Uh-huh.
on in their life, they appear like they have a senile upper lip.
And is the lip lift something that was already common in the plastic surgery world? I mean, something that
Yeah,
they
good
were.
question. So
Okay.
it's been around for 30 years, but not a
Okay.
lot of people were doing it because of the scar. And
Okay.
it's one of these things, it's like, I know you're really into bonding, like we are, people say you can't bond to dentin, right? Well, yeah, you can't
Uh-huh.
bond to dentin if you don't do it correctly.
Yeah.
And it's the same thing with lip lifts. Yes, you'll always get a scar if you don't do it correctly. And
Okay.
so it took so many years to evolve the treatment that it could be done routinely because the
Okay.
initial procedure just had surgical principles that were incorrect.
Okay.
Yeah.
Okay. So it's, I mean, like, yeah. I kind of wondered about that because it's,
Oh, Bill's on. Hey,
you
Bill.
know, there he is. Um, but yeah, I figured it was something that they maybe had in their world before coming to our world. I mean, is there a lot? I mean, like if I went to my plastic surgeon here in Birmingham, you think that if I said, "Oh, I have this patient that needs a lip lift," do you think that that plastic surgeon would say, "Oh yeah, that's something I can do for you," or they'd look at me like, "I don't really do those."
Well, what I learned is that not a lot of people are doing it because they did it, once or twice. They had a scar and they said, it doesn't work anymore.
Okay.
And so I was going around to plastic surgeons because I had this idea 10 years ago. Well, actually, 11 years ago.
Okay.
When I was still in dental school, I started talking with plastic surgeons and they were like, I do like one a year, maybe, but it's just like really, I never really like how it turns out.
Yeah.
And I'm like, this would be revolutionary for dentistry if we could just
Yeah.
put the patient's lip in the correct position. And
Yeah.
then it really took me finding Dr. Talley when he was like, oh yeah, I do like, 8 a week. I'm like, what?
Uh-huh.
And and I
Yeah.
saw his cases and they were like amazing. And so it's like,
Yeah.
what have you done to change this? How do you make it so routine? And that was when we looked at how he makes his markings before surgery. And I can show you some pictures of this too. And
Okay.
and how he releases the tissue. That was what really changed everything for me. I think people are asking about the surgery. Let me show
Yeah.
some videos, okay?
Yeah, absolutely.
Or some
Yeah,
photos at
and
least.
while you're turning it, like I feel like that's such a big thing is to like you can know about this stuff, but like if you can't find someone that can work with you to do it, it's like I had the same problem with I had for allergies. I had needed a patient that had an allergic reaction to dental materials, and they got referred, and like trying to find an allergist that had they have like there's certain like kits that they can use to test different types of dental materials was like I like searched the entire United States to find someone that could do this, and you think since that's it's a referral thing, you don't really know what your referrals can do until you kind of talk to them, especially when they're
Yeah.
outside of dentistry. So,
Yeah, well, that's why I would,
um,
it's a hard thing. People always say, like, how do you find a plastic surgeon that does this? You just
uh,
gotta call, make friends, and we've had people in the oral facial club that started off never doing this, and then they
oh,
learned our techniques, and now they're doing it all the time.
okay,
So you need to find someone who's open to it. I think just as much as we can blame ourselves in the dental world of not incorporating medical procedures, the
uh,
medical community can be even worse too. They're like, why would I work
yeah,
with a dentist? Like, you do the teeth, I do everything else, and that's how it is. So
okay,
finding someone that has a personality that's willing to learn, and that was how Dr. Talay was for me. He's like, oh,
uh,
cool. Oh, that's so awesome. I always see these people that have terrible teeth, and I would love to be able to like make their whole mouth plan it all at once.
uh-huh.
So yeah, it's not as easy as I would have liked. So this is the procedure here. Okay,
Okay,
so these are the lines that Dr. Talay really brought on to make it more predictable to line up the incision afterwards, because that was another thing is people were having a problem lining up the incision when it was done. So
okay,
that is the amount that we're going to take away, that little kind of,
little mustache.
yeah, little mustache there, bird. Okay, so the incision is made, and this goes to between the fat and the muscle. So there's no muscle that is being incised, and that's important.
Okay,
So we are, okay, so this was just taking off that skin.
okay,
And now this was the part that Dr. Talay really innovated here, was releasing this tissue. So right now, what everyone else would do is take this and sew it up. But then you
uh-huh.
have a lot of tension on the flap. So what Dr. Talay does is goes in and releases this, sometimes all the way down to the commissure.
Huh.
So a very big flap, which is one of the reasons why it takes longer to heal with our technique than it does with other people's techniques. So then we
He's
make our
releasing it
incisions,
somewhere. Okay,
or sorry, then we make our first internal sutures, external sutures. Now her lip is getting very swollen because of all the releasing.
uh-huh,
That's not how she'll look at the end. Internal and external sutures. Most people just do external sutures. So we do
uh-huh,
internal and external. Here we are at about 5 to 7 days, removing the sutures.
okay.
Let me see if I have some, let me show you some more cases here. Okay, this is a good one. So this is a video here. So this patient was in her early 30s. She's Asian female, no tooth display at rest, no papilla
Yeah.
display during smiling either. She had some fillers previously. So we're measuring how much we're going to remove. We do internal and external anesthesia here. Most of these patients are done in just like sitting there. They're not sedated or anything.
Oh, really?
Yeah. So
Not even conscious sedation or
I
just
mean,
nothing?
usually if they're getting other procedures done like facelift or nose job, then of course. But if they're just
Oh,
doing lip lift, takes about 45 minutes. Most patients just local anesthesia.
oh my gosh. Okay.
So there's the skin that's removed. We'll use cautery to control the bleeding.
Okay.
This makes the healing a little bit better.
And you've already done your releasing?
No, not yet.
Yeah, okay. Oh, here it is.
So this is part of the release. So So releasing all the way down, sometimes to the commissures, all the way down to the vermilion border. And then this is where really the magic happens. This is what we've all wanted to do for so long with our patients. We have our internal suture, first one, and this is going to see.
Internal, does that mean below the skin?
Yeah.
Or...
Yeah, so right here,
Okay.
here we go. Boop, pulling that up. So now instantly she looks younger. Now what you'll see is as we start suturing, the lip will get more and more inflamed and the lip will look really gigantic for a while.
Okay.
So internal suture on that side, all the internal sutures on the left side, and then we start the external
How many sutures do you think
sutures.
that is on either nostril?
It's a lot. I can't remember what it is. I think it's like 10 internal and like 30 external, something like this.
Cool.
Yeah.
Oh, what kind of sutures are those? Somebody asked that.
I have to look that up. I have the list of everything from when we gave our course in Brazil, but I can't remember offhand.
Okay.
Yeah.
Thank you for showing that.
Sure.
I was like, for me, I mean, this is so far outside of my world, but like, it's neat to see, actually how you guys do it. And then, sitting there and I'm still thinking about that first picture you show of the person that's got the little lip that kind of sticks up like that. And that does, I mean, it's a very attractive kind of, I mean, but the most people's lip kind of, I never thought to look at a lip that if you look at them from the profile, if they kind of turn up like that.
Yeah, that's called lip eversion when it folds out like that. Yeah, so that's a very young, kind of sexy look. And both for men and women, it has kind of been shown to be more attractive. You know, a lot of how this happened was I was in the modeling world and I was seeing all of these young, beautiful people, and I was in dental school at the time, so I was looking at all their mouths, and I realized that they were almost always the same, no matter what, what race they were, what gender they were, where they were from. They all kind of had this inferior bow to the lip. So the lip goes like this instead of falling. Okay, it goes up like that, like an inferior arc, inferior bow. They had an everted upper lip. Okay, so a concave philtrum. They all had short philtrums, and they showed a lot of tooth display at rest. And it was all the same. Men, women, dark-skinned patients, light-skinned patients, Asians, Latinos, all the same. And so I started realizing, like, this must just be a attractive look that, humans are attracted to. So I started looking into the science of beauty and psychology and why we think things are beautiful and how they study babies and how babies spend more time with people that are perceived as being more beautiful. Because I had my older patients in dental school that said, I'm getting these dentures finally, I want to look younger. And what all my faculty was telling them was like, we're going to make your teeth longer, you're going to look so much younger. And what was happening is we were making them look like the Grinch, is this super long upper philtrum, because we were prosthetically giving them vertical maxillary excess.
I'm used to thinking about, because it's funny because my grandfather was a physician and he had a good friend that's a plastic surgeon. So like all my mom's side of the family all had their noses done. And so like I know that you get the little nose, and like I've seen kind of like the aesthetic looking nose, and people that have had surgery done on their nose, and it's kind of like cute little upturned little nose thing. But like the lip, it was like when I looked at that lip and you saw somebody else was mentioning this about how a lot of times an aesthetic patients, or the aesthetically driven patient, actually wants to show more, sometimes even more than the 3 to 4 millimeters or the 1 to 2 millimeters if they're male, that they want to show 4 plus, 4 or 5, or the males show 3 or 4 of incisal display, because that's in the, I guess, aesthetically driven.
That's part of it too, is that if you look at the most beautiful people in the world, and especially the most beautiful women in the world, they don't show 2 millimeters. They show like 8 millimeters at rest, 6, 7 millimeters at rest. And
All
so
right.
that was another thing, is I started seeing like I'm being taught 1 to 2, but if you look at like, you know, the top 10% of who we would perceive as being beautiful, they show much
Uh-huh.
more.
Okay.
And so that's
I,
why I think the mock-up is so important.
okay. I was thinking about myself. I like show at rest. I show no tooth, and I've noticed every time I look at a picture of myself, it's like a candid picture. I always look like I'm pissed off,
Yeah,
and I'm like, I wonder if that's the I show zero. My dad's the same way. He
yeah,
shows zero tooth display at rest, and he
yeah,
always kind of looks pissed off too if he's not smiling. So,
yeah. I get
um,
this from my patients. You know, my patients will
uh,
come in, you know, let's say they're in their 50s, 60s, and they say, you know, my grandkids always say I look mean. So can you
yeah,
make the teeth longer? I see these young people, and when they talk, you can see their teeth, and I really like that. I'd love to see that. And sometimes
mhm,
we can if the lip is in the correct position. But if it's
okay,
not in the correct position, then we have to kind of inform the patient, you know, yeah, we can lengthen your teeth, but that's not going to make you look better from like a proportion standpoint or a natural beauty standpoint. It'll actually look unnatural for you. To
okay,
be more natural, we should shorten your lip. And what
okay,
I like about this is you get more invasive, let's say from the surgical standpoint, but you can get less invasive with from the dental standpoint. So, you know, not as
okay,
great for our pocketbook, but
yeah,
really good for saving tooth structure. Because
yeah,
patients that will come in and say, you know, I want 10 veneers because I need to lengthen everything, we can say, well,
mhm,
maybe you just need like some clear aligners and bleaching and bonding.
yeah,
And we can save so much tooth structure. We can save you money. Although you have to spend more money, you know, with a plastic surgeon, you'll
yeah.
save the money here. You'll save the tooth structure here. We can be less invasive.
Yeah. Yeah, no, that's a great point. I mean, because sometimes it's that, you know, from coming from Alabama or something, you hear about, plastic surgery and it sounds invasive, but when you think about it as, like you just said, if you're doing less to hard tissue, and I always value hard tissue
Right.
a lot, so like, if you don't have to do as much to the teeth. Um, I want to switch gears a little bit and ask you about, do you mind? So it's the oral facial
Or a facial club.
club.
Hmm.
Can you what is that?
Yeah.
Do you
So
mind?
that started with Christian Coachman, and he
Okay.
had this idea of treatment planning, having a team of people that can treatment plan and that really understand the face. And Christian
Okay.
and I were lecturing together in Indonesia, and he saw me speak about the lip factor. And he saw like the last 5 minutes of my lecture, but I was talking about the
Okay.
lip, and he comes after me and he goes, "Hey, what was that thing that you did with the lip? Can you teach me that?"
Oh.
So we started showing him all this stuff, and that was when him and I really expanded the oral facial club. So the idea
Okay.
was to bring in people that are at the top of their field in dermatology, plastic surgery, sleep medicine, orthodontic surgery, cosmetic dentistry, ortho. I mean, any specialty that you would need in the face. And because we were all dentists, we started with a dental team. But then I started bringing in
Okay.
plastic surgeons. Some of our other dentists started bringing their friends that were plastic surgeons or dermatologists. So we have this team now of kind of thought leaders that are working together on cases and trying
Okay.
to bring together the whole medical community so that we can treatment plan together and say, you know,
Okay.
not, okay, you come to me to do the teeth, you go to you to do your facelift, you go to you to do your skin. But no, let's get
Okay.
together and say, what's the best for this patient? If I do something to the lip, is that going to affect your teeth? Or if I change
Okay.
the teeth, but the orthodontist was going to put the teeth up or down, you know, we have to think together. And it's
Okay.
hard enough to get a bunch of different professionals just in dentistry to communicate.
Yeah.
I mean, this is something I always talk about with the implant world is like just to get surgeons and restorative doctors to talk to each other is so difficult. But when you think
Yeah.
of like getting a prosthodontist and a GP and an orthodontist and an orthodontic surgeon all together, like that is very
Uh-huh.
difficult. But that's really our goal. We want to
Okay.
educate the medical community on what we do, and we want the medical community to educate us on what they do. Because we
Okay.
don't have to be able to do everything, you know. I'm not going to do
Okay.
orthodontic surgery. I'm not going to do lip lifts. But I need to know what's
Uh-huh.
possible so that I can include it in my treatment plan for the patient.
Yeah. And then find the group of referrals that understand that can do the things that you want to be able to do.
Yeah.
Um,
Yeah, and so with the Oral
how
Facial
long?
Club, we are also kind of research based too. We're all
Okay.
pushing out a lot of research on different protocols, like what you were talking about with facial flow, and with our video documentation and gummy smiles, and we're publishing one on lip measurements right now. But we want to be
Okay.
producing research for the medical and the dental community so that people know guidelines on how to design smiles and faces.
Okay. So you guys are so they're not necessarily a protocol as of yet, but that's what you kind of maybe so working on the research,
Yeah,
gathering guidelines, and then um, yeah, I mean so I guess moving on to that facial flow concept, as I was reading about it, is kind of the idea, right, that there's not every face is symmetrical, and there's some faces that have uh, components of the face
yeah,
offset, and then uh, from a dental perspective, is the biggest impact of that like how you're designing? I mean, it's more than just midline. What's like
yeah.
how
So it's
would that facial
midline
flow?
and cant. So this idea came from my good friend Bruno Pradera, who is in Spain, and
Okay,
he had showed this to Christian, and then Christian brought our research team together. So it's Bruno Pradera, Christian Coachman, me, and Eduardo Mann from Chile. So that's like our
okay,
research group with the facial flow group, and we're publishing a bunch of other stuff now. But the idea was we have always been taught in dentistry that the facial midline is straight
uh-huh,
and that it has to be perpendicular to the eyes, let's say. And we
okay,
started looking at faces and realizing, well, it's definitely not perpendicular to the eyes always, but nobody is symmetrical. So how can you have a straight facial midline?
okay,
You can't. If you have an asymmetrical figure, you can't have a straight facial midline. It actually has to curve in some ways. So like when you look at my face, and let me look into the thing here.
okay,
Okay, so mine, we measure 5 different points, or sorry, 4 different points. The glabella, the tip of the nose, the philtrum, and the tip of the chin. What you see with
uh-huh,
my nose is that my glabella is here. My nose kind of curves this way. Then my philtrum comes back left, and my chin finishes to my left. So my facial
okay,
flow goes like this and finishes there. So what we find is that this lower third of the face, when we're designing smiles, your facial midline should be parallel with your facial flow line. That doesn't
okay,
mean that it has to be perpendicular to the eyes.
okay.
And it may,
So if it's
excuse
like,
me, it may even
uh,
look better if it's not perpendicular to the eyes, if it follows the flow of the face. So you ideally would want it to be at the point of the facial flow line, but
hmm,
if it's not there, you want it to be parallel. So let's say my
hmm,
facial flow line is here, right? If my
okay,
facial midline isn't there and it's over here, that's fine if it's parallel. But if it's going the opposite way, what you're going to see is
uh,
visual tension.
okay,
So our brain looks at multiple points and creates a line. And it's a feeling that has to happen. And we've all done that with aesthetic cases, right? We've like done a mock-up, looked at it and just said like, I don't like this, but I don't necessarily know why. And a lot of that is because we have so many other influences. So we have vertical influences, horizontal influences, and we're writing our second facial flow article right now about the horizontal component. We have to
okay,
take all of these into play to figure out where the two central incisors need to go. And
okay,
and it's a lot of work, but that's what we need to do to put that there.
okay. And as you've looked at faces, I mean, I'm sure as you're like coming up with this stuff, you probably like go to the grocery store and you look at a face, and you're like, oh, this one goes this way, that one goes this way, this one goes this way. I mean, I mean, I haven't. yet. Like, I mean, how common do you think it is? Like, I mean, as you've looked at faces, do you notice them all the time now? Like these
It's
facial
something you
flows? Or,
can't unsee. It's definitely
okay.
definitely true. Once you learn about it, you
Uh-huh.
realize that almost everybody, very rarely do people have a straight flow. So they always have
Okay.
some type of flow, but very rarely is it straight. Even the smallest little cant or curve can change it. And so, yeah,
Okay.
you know, if nobody is symmetric, then, technically everybody has facial flow. Someone messaged me that our comments are off. I guess that's because I was showing
Oh,
videos, huh?
sorry. Um, I turned them. Sometimes I get like these people that get real mad and they say turn off all the comments. They can't
I
see,
know,
and so
I
then I
know.
turn off the comments. So I just got in the habit of doing that before I get yelled at about turning them
Yeah.
off. But, um, but no,
Yeah.
I wonder is that I was thinking about when you cut a under the symmetry, like you've seen like those photos where they've done stuff like they cut Elvis's face in half and they
Yeah.
like put it together
And
his
it
left
looks
half and then
terrible, right?
it looks totally different. So is
Yeah.
that's the same thing?
Well, what we've learned is that, we're naturally attracted to certain things, and humans are naturally attracted to asymmetry because
Uh-huh.
so much of what we see in other people is asymmetrical. So
Uh-huh.
that's asymmetry is really the rule. It's not the norm. It
Uh-huh.
it is really the rule. The rule is asymmetry. And it's the same thing with teeth. Teeth aren't symmetrical as well.
Hmm. I think I was reading that somewhere in one of the papers that you guys put out is that like, symmetry is more important close to the midline, and then as you get
That's
further
right.
away from the midline, the
Mm-hmm.
symmetry is less important.
Yeah.
It's like if you're going to do characterization and stuff, you can get more crazy out
And the
towards the periphery.
canines. Yeah. Yeah, that's
Okay.
right. Yeah.
Okay.
Yeah, because we
Um,
look, we look at people's eyes, then we look at their mouth. But when we look at their mouth, we take everything into account, and then when we go deeper, we kind of look through the central incisor area.
okay.
Yeah. But it's
And is
it's
that
a
something that?
it's this
Okay. Go
idea
ahead.
of like a composition, designing a smile. Everybody wants it to be a cookbook, and they want it to be mathematical, but it's like an art piece, it's like a composition. And that's what makes it so difficult to teach too. And that's why we're,
Uh-huh.
we're really trying to give protocol cookbooks to guide people. But,
Uh-huh.
when you're dealing with asymmetrical frames like the lips or the eyes or the jaw, and then you have asymmetrical teeth, setting them so that the composition, the overall gestalt of the smile is good is not easy.
Okay. Um,
But
Someone was
explain Kim
commenting about.
Kardashian is symmetric and she looks great. What do you think? Do surgeons follow symmetric face? There's no way she's symmetric. No,
Okay. Yeah.
there's no way
I was
she's
gonna say.
symmetric. I would just disagree. Yeah. Now, people have more asymmetries than others, so maybe she's less asymmetrical, but there's
Mhm.
no way she's symmetric. It's not possible. Nobody is. When you look at the
Yeah.
most beautiful faces in the world, you look at Angelina Jolie or Brad Pitt or any of these kind of famously beautiful faces, they're very asymmetric, very
Oh,
asymmetric. Yeah.
I
And
didn't
we've
realize
done that
that.
a lot.
Okay. Yeah, I feel like I always think of that's his. He's just the midline guy. Tom Cruise is his.
Tom
I
Cruise,
think
yeah,
his
his
his face
midline's
is
off like
probably
three
close.
millimeters.
Yeah.
Yeah,
Um.
I analyzed his face with the facial flow actually. Let me see if I can pull it up. That
Okay.
that would be
Yeah, I feel like
interesting to
it's more
see.
than just his midline. If you really look at his face, it's kind of like it does a lot of weird things.
Yeah, I think if I remember correctly, I think he has what we call a disruptive facial flow, which is where it goes
Okay.
it goes one way and then it kind of curves back. So let me see if I can find it here.
Yeah, I was looking at. I was watching somebody's video outside of dentistry on Instagram today, and the guy had like a very unusual face. He even had like an con inverted smile line,
Yep.
but it still looked somehow it fit, and it looked okay.
Okay,
Okay,
so
yeah,
now you're gonna want to turn the
this is
comments off
Tom.
or else
Okay.
they're gonna yell at you.
Oh yeah.
Okay, so let me see if I can make this not be so. There we go. Okay, so you look at his smile. Now the first thing that we're gonna do is analyze his, oh, here we go. So this is like the mathematical approach, right? What everybody would do. They would take him and not put him in the natural head position. They would make sure that his eyes are parallel to horizon, and we don't do that anymore. We keep our patients in the natural head position. Then, you know, traditional treatment planning would say, okay, you take his eyes and then you make the midline perpendicular to that.
Okay.
And then we would, so what we do is we keep him in his natural head position. We take some of the horizontal reference points. We make our vertical reference points, which is the glabella, the tip of the nose, the philtrum, and the chin. You see how far his chin goes to the left, right?
Yeah.
And so his facial flow.
Oh, yeah.
Here, let me show it here. His facial flow line is like this. Now, what you see is that his midline is actually perpendicular to his facial flow line. Now, if it was going the other way, it may be perceived as being less aesthetically pleasing.
Okay.
So ideally, we would want his midline to be where the facial flow line is. But because his is, right? Well, I mean, we would want to be on top of it.
Oh, sorry. Yeah, that way.
The midline,
but it's parallel.
But
his
parallel hand is parallel to it, yeah. So that's why, and then we say a green side and a red side. And
yeah,
that's
I saw that.
why,
what does that mean?
Yeah, so the green side is the side on which the facial flow goes to, kind of ends that way. And you always want to err on the side of the green side. So you want, if you have a cant, you want it to cant towards the facial flow. Okay, so here's this smile here. And when you look at this smile, you see incisal edges are worn, canines are kind of off, right? Gingival margins show more gingival margin on one side than the other. Laterals maybe a little too long. Well, this is my face. Okay. So if we analyze me in my natural head position, that's horizon.
Okay.
My eyes are 2.5 degrees off of horizon. My commissures are 4.5 degrees off of horizon, so 2 degrees off of my eyes. And when we do my facial flow line, my facial flow goes towards my left, and my commissure comes up to match that. So we have my glabella, tip of the nose, philtrum, chin, and that's really my facial flow line. And what you see, you know, I have a lot of patients that say like, oh, I love your teeth. I'd love to have your teeth. And as dentists, if we analyze my smile, we'd say, oh my gosh, he needs, you know, crown lengthening on the right side. He needs to do all this stuff. But because I think my midline is parallel with my facial flow line and my teeth are generally straight and generally bright, patients are okay with it.
Oh, wow. So is that when with the 0, the 2.5, and 4.5, is that when you're talking about the horizontal?
Yeah, so that's the horizontal component in relation to the vertical component. And that more has to do with like keeping the patient at a natural head position. Okay. Because I was taught originally, like, you know, you take your picture and the patient's like this. The first thing you do with the picture before you start designing the smile is go like this, right? But then we have some videos of patients, and we have some really good ones from Bruno, where in the video, the patient's smile looks great. But in the picture, once we made this correct, it looks like they have a cant. And so what we have to remember is if someone always holds their head like this, that's how they're going to be perceived. And that's how we need to plan the case. We have to basically take into account the frame. If we're not going to change anything with the frame, then we have to match it to that frame. If
Okay.
we're going to change something, like if we're going to do Botox to change the commissures, or if we're going to do orthodontic surgery to change the jaw, or gingivectomy or crown lengthening to change the gingival margins, then we don't have to take those into account. But if we're
Oh,
not going to change something, then we have to go with the flow, is what we say.
okay. Well, the 1 hour Instagram kicks us off, and I was like, I always
Yeah.
felt awkward if it likes kicking us off as we're talking. So I figure
Should we come
we
back on
got
and finish up? Or
um
are you good?
yeah. I mean, we can. I mean, do you have? I have. I like messed up my whole schedule today, and so I'm already back home from work, so I have nothing else to do. I mean, I don't mind.
Yeah, let's jump back on
Actually,
and we'll finish up.
okay.
Okay. See you back
Let me
on.
think. I guess I'll end it. Yeah.